This video is on pelvic inflammatory disease. Pelvic inflammatory disease occurs when an infection from the vagina or cervix travels up to the endometrium and uterine tubes. Let's understand how this occurs. Normally, the endocervical canal acts as a protective barrier against potentially harmful bacteria in normal vaginal flora. However, if the canal is disrupted for whatever reason, such as an STI from a gonorrhea or chlamydia infection, birth, IUD, vaginal bacteria gains access to travel up. It can reach the endometrium, uterine tubes, ovaries, peritoneum, or liver. And this relates to the symptoms, although patients are commonly asymptomatic. The cardinal sign is lower abdominal pain. If there's salpingitis, there may also be abdominal vaginal bleeding. There may also be yellow malodorous discharge, dyspareunia, fever, and nausea and vomiting are also common. The two parts of physical examination are bimanual palpation and using a speculum. Bimanual palpation may elicit cervical motion tenderness, uterine fundal thickness, and adnexal swelling or masses. A speculum may reveal yellow endocervical discharge, endocervical bleeding, and inflammation. An equivocal diagnosis should not prevent treatment. Diagnosis requires an endocervical swab and a microscopy, culture, and stain for gonorrhea and a PCR for both gonorrhea and chlamydia. FBC, UECs, and LFTs as usual, taking particular note to Fitzhugh-Curtis syndrome in LFTs, which we'll talk about later. A transvaginal ultrasound may reveal abscess or adnexuses, an increased tubal thickness, so greater than 5 mm. Laparoscopy is needed to identify salpingitis. There are acute and chronic complications that relate to where the infection spreads. Acute complications include hydrosalpinx, pyrosalpinx, tubal ovarian abscess, and perihepatitis known as Fitzhugh-Curtis syndrome. Chronic complications include recurrent pelvic inflammatory disease, chronic salpingitis, and hydrosalpinx. Adhesions increase the risk of tubal infertility and ectopic pregnancy. Finally, bowel obstruction is possible. Management as usual can be split into supportive and definitive management. Supportive management includes analgesia in removing the IUD from the patient, if it's present. Contact tracing of recent partners, so the last 6 months for chlamydia and the last 2 months for gonorrhea. It is necessary to educate the patient in terms of abstinence during treatment and 1 week after treatment, and counsel on the importance of barrier contraception to prevent STIs and pelvic inflammatory disease. Definitive management includes antibiotics. In non-severe cases, this includes ceftriaxone stat and 14 days of oral doxycycline and metronidazole. In severe cases, IV ceftriaxone, metronidazole, and azithromycin is required. Surgical options include laparotomy and drainage procedures. Thank you for watching. If you learned something, please tell a friend who may also find it useful.